between ventricular tachycardia versus ventricular fibrillation. So definition is greater or equal to 3 consecutive ventricular beats at rate of greater or equal to 100. Usually it is 120 to 150, 120 to 250. It can be monomorphic, or it can be polymorphic. So greater or equal to 3 this consecutive ventricular beats at rate of more than 100, usually 120 to 250, and it can be monomorphic or polymorphic. Now what is VFib? VFib is chaotic. So this is chaotic disorganized ventricular activity. Three things. One is chaotic disorganized ventricular activity with no effective contraction and no QRS complexes identifiable. So this is the definition of ventricular fibrillation. So chaotic disorganized ventricular activity. Chaotic disorganized ventricular activity. There is no effective contraction. There is no QRS complex identifiable. And mechanism of ventricular tachycardia and ventricular fibrillations. You see, there can be re-entry circuits, or there can be triggered activity. As I already mentioned, the triggered activity can be due to early after depolarization, when it reaches threshold, or delayed after depolarization. When both reach threshold, they trigger, leading to ventricular tachycardia. Whereas this is because of multiple re-entrant wavelets throughout ventricles, and there is complete electrical chaos. ECG will be showing here. So ECG will be showing here wide QRS tachycardia, regular or irregular. You can see capture or fusion beats, whereas here it will be irregular, and there will be no organized QRS, so it will be completely erratic. And hemodynamics, you see, ventricular tachycardia hemodynamic, it may be tolerated for a short period, especially monomorphic VT in structural heart disease subjects, and this is immediately fatal. There is no cardiac output. It requires defibrillation. So you see, treatment, if it is stable VT, you can give antiarrhythmics like amiodarone, lidocaine, but if it's unstable VT, you have to go for cardioversion. And for torsion disc points, you give magnesium sulfate plus minus overdrive pacing. So in nutshell, VT is rapid but somewhat organized ventricular rhythm, while VFib is a complete disorganization with no cardiac output. VT may sometimes be tolerated briefly, but VFib always causes sudden cardiac death unless reversed. So VT requires cardioversion. So this requires cardioversion, and this requires defibrillation. Now, why is it important to distinguish VT versus VFib in a case of primary aldosteronism? Importance is there. VT can be the initial presentation of Conn's. This can be the initial presentation of Conn's, but patient can progress into VFib. That causes sudden cardiac death, sudden cardiac arrest. So that's why recognition is important in this case. And why is triggered activity different from re-entry? Because triggered activity is abnormal depolarization. Triggered activity is simply early after depolarization or delayed after depolarization. These are simply abnormal depolarization due to ionic disturbances, and that when reaches to threshold, it triggers activity. So in nutshell, normocalemic primary aldosteronism is common around 60 to 80%, and VT is organized, whereas VFib is disorganized or chaotic, whereas VT is treatable and VFib is almost fatal. What is the definition of resistant hypertension? Resistant hypertension, as per AHA or European Society classification or JNC guidelines, Resistant hypertension is blood pressure that remains above the target goal despite concurrent use of 3 antihypertensive agents of different classes at optimal or maximally tolerated doses, one of which should ideally be a diuretic. And alternatively, if blood pressure that is controlled but requires greater or equal to 4 medications is also considered resistant hypertension. What are the causes of true resistant hypertension and pseudo resistant hypertension? First is what are the causes? True, we know primary aldosteronism is one of the causes, but pseudo, for example, poor adherence to therapy. Poor adherence to therapy is one, and white coat effect. That's office BP high but ambulatory BP normal. Third is inadequate drug regimen, suboptimal doses, so you are missing a diuretic. Also, poor BP measurement technique. As we know, primary aldosterone can give rise to secondary resistant hypertension. So what are the other causes of resistant hypertension? So you have to consider, first one was this Conn syndrome, as we described. It's very common among resistant hypertension cohort. It comprises 20%. Also renal artery stenosis is another thing. CKD is another thing. Obstructive sleep apnea, pheochromocytoma, Cushing's, thyroid disorders. So these are the causes or secondary hypertension causes. So you have to rule out first. So you have to rule out first Conn syndrome, renal artery stenosis, CKD, obstructive sleep apnea, pheochromocytoma, Cushing's, thyroid disorders. So whenever you are eventually labeling a patient having primary hypertension or idiopathic hypertension, and you are going to treat it with 3-4 drugs, but you have to rule out these conditions first: Conn's, renal artery stenosis, CKD, obstructive sleep apnea, pheochromocytoma, thyroid disorders, and Cushing's. So you optimize therapy. Even though we give this one at least diuretic. So triple therapy backbone is ACE inhibitors or ARB plus calcium channel blockers plus thiazide-like diuretics. So thiazide-like diuretic you can give chlorothalidone or you can give indapamide. If still uncontrolled, you can add spironolactone or eplerenone if primary aldosteronism is suspected. We described VT versus VFib some minutes ago, and we said here we cardioversion and we give here defibrillation. So what is the difference? You see, this trips up many people. The key difference is whether the patient has an organized rhythm with a pulse versus chaotic rhythm or pulseless. So we know VT is organized rhythm and this is disorganized or chaotic and a pulseless condition. So synchronized cardioversion is the shock is delivered synchronized to the R wave of the QRS. It is a defibrillator that times it. So why? Because it avoids delivering shock during the vulnerable repolarization phase, that is T wave, which can precipitate ventricular fibrillation. So indication, what is the indication? For instance, one is unstable tachyarrhythmia with a pulse, for example. So indications, broadly we say unstable tachyarrhythmia with a pulse. So this is the broader indication. Now we have to categorize which arrhythmias will come under it. Unstable tachyarrhythmia with a pulse, this is important. Patient should have a pulse, but if it is pulseless, then you have to give this defibrillation. So, and second thing is, here we said tachyarrhythmia and unstable. So unstable tachyarrhythmia but with a pulse, you have to go for synchronized DC cardioversion. Whereas if it is disorganized rhythm and pulseless, then you have to go for defibrillation. So what will come under this? You see, because tachyarrhythmia but with a pulse and unstable. You see atrial fibrillation but unstable. Second thing is unstable but SVT, supraventricular tachycardia. Similarly unstable but monomorphic VT, because monomorphic VT unstable has with a pulse. You give synchronized DC cardioversion. But if a patient is, what do you mean by unstable? What is unstable? What is unstable here? Unstable is patient has hypotension, patient has chest pain, patient has altered mental status, patient has shock sinus, patient has acute heart failure, but still has pulse. This is very, very important, but patient still has pulse. So if patient still has pulse but is unstable, patient has hypotension, patient is in acute heart failure, patient has chest pain, patient is in altered mental status, patient has shock signs, then you have to go for synchronized DC cardioversion. So indication is unstable tachyarrhythmia but with a pulse, you go for DC cardioversion. So it can be unstable atrial fibrillation, unstable SVT, unstable with monomorphic VT but with a pulse, you go for synchronized DC cardioversion. Whereas defibrillation, you will go for you give unsynchronized shock, and indication is chaotic rhythms or pulseless patients. For example, patient has pulseless VT. Second thing is ventricular fibrillation. So only two indications. One is pulseless VT and ventricular fibrillation. So pulseless VT or ventricular fibrillation. Here no synchronization is possible because there is no organized QRS complex. So why synchronization is not required here? Because there is no organized QRS. So these are shockable cardiac arrests. You say one will maybe question that if pulseless, isn't that also unstable? You see, pulseless is the extreme form of instability, but terminology in ACLS separates them. One is unstable with a pulse, and another thing is pulseless. So unstable with a pulse, it means still some cardiac output but inadequate. So synchronized cardioversion to restore organized rhythm safely, but pulseless means cardiac arrest. Immediate unsynchronized defibrillation plus CPR is to be given. So in nutshell, unstable in ACLS means critically ill but not in cardiac arrest. So unstable in ACLS means patient is critically ill but not in cardiac arrest or not in full arrest. Pulseless means patient is in arrest. So pulseless means arrest. That's why when you give pulseless VT, it means cardiac arrest, and when you have VFib, it will already be pulseless. In both these scenarios, you go for defibrillation. So here is the catch. So if you come across any patient who has ventricular tachycardia, and there are two scenarios possible. One is monomorphic VT, another is polymorphic VT. Usually the incidence of having a pulse in monomorphic VT is more than compared to pulseless VT. So you will end up seeing polymorphic ventricular tachycardia in a state that is pulseless. So in such a condition, you have to go for defibrillation plus you give CPR in such a case. But sometimes monomorphic VT and polymorphic VT can have pulse. So, and there is pulse, but patient is unstable. That is, patient has hypotension, patient is in acute heart failure, patient has chest pain. So it's like these things that we already described: hypotension, chest pain, altered mental status, shock signs, acute heart failure. So these are the unstable conditions. So you have to go for this synchronized DC cardioversion. So if there is a pulse and the patient is unstable, you go for synchronized DC cardioversion. Remember, this state is arrest, called cardiac arrest. So synchronized cardioversion is used for unstable tachyarrhythmias with a pulse, because we must avoid shocking on the T wave. Defibrillation is unsynchronized and reserved for pulseless rhythms like VFib and pulseless VT, where there is no organized QRS to synchronize with. Now, thing is, why channelopathies are a differential in Conn's patient with VT? Or because you see, if you come across a patient with VT because of hypokalemia and you found ARR is positive, aldosterone ratio is positive, and you doing diagnosed to him Conn's, you cannot straight away label that patient that it is because of Conn's that patient had ventricular tachycardia, because you had to rule out other diagnoses. So channelopathies is a potential one. Channelopathies is inherited arrhythmic syndromes with structurally normal heart. One is long QT syndrome, that is congenital, and that has got prolonged corrected QT interval, and there is risk of torsades points polymorphic VT. Second is Brugada syndrome. Patient has code ST elevation in V1 to V3, and there is risk of VFib VT, and there is also, always remember, there is family history is strong here. So one is long QT syndrome, congenital, and what you will observe here, prolonged QTC corrected interval. There is risk of torsades points and VT. And another thing is Brugada syndrome. This is a congenital anomaly where you will see code ST elevation in V1 V3, and there is strong family history positive. Third thing is CPVT, that is catecholaminergic polymorphic VT. It is stress or exercise induced bidirectional VT. It is a normal baseline ECG. It is a normal baseline ECG. So in primary aldosteronism or Conn's syndrome presenting in VT, the cause can be Conn's hypokalemia, or could be due to underlying these channelopathies, that is long QT syndrome, congenital, prolonged QT corrected interval, Brugada, where there is this code ST elevation V1 to V3, and strong family history, or this catecholaminergic polymorphic VT, stress or exercise induced bidirectional VT with normal baseline ECG. So these can be unmasked. So this can be unmasked in the presence of electrolyte imbalance. So these becomes a differential diagnosis when we are dealing with a case of Conn syndrome related hypokalemia with VT. So let's discuss this QTC interval. So normally QT interval is equal to onset of QRS to end of T wave. It varies with heart rate, that shortens at high heart rate and lengthens at low heart rate. So there is inverse relationship. And corrected QT interval is QR adjust for heart rate using Bezet's formula. So that is QT corrected into QT to under root of RR. Normal QT corrected is equal to 440 in males and less than 460 in females. In hypokalemia, what happens? There is this QT actually QU interval, it gets prolonged, but it should normalize when potassium is corrected. That's an expected response. But what happens in congenital QT, for example long QT syndromes, what happens in such cases? You see in congenital there is QTC is prolonged, and you saw, for example, hypokalemia. So you thought this is because of hypokalemia, and you gave correction. You gave IV KCl. So you give IV KCl. Potassium, serum potassium became normal 400, but you found that there is still QTC prolongation. That there is underlying channelopathy. You have to suspect that condition at that time. So if QTC stays prolonged after potassium correction, you have to suspect congenital long QT syndrome. That is channelopathy instead of just hypokalemia. So you can how you can rule out channelopathy in this case, you have to ask history. There is family history of sudden cardiac death, syncope, unexplained drowning, arrhythmias. You have to check ECG after correction of potassium, and in Brugada look for classic ECG changes, that is code ST elevation V1 to V3. Especially in Brugada you will see these changes fever induced. And this catecholaminergic polymorphic ventricular tachycardia, it will be normal ECG, but when a patient will perform any exercise or there will be any stress, it will induce bidirectional or polymorphic VT. So genetics, consider if suspicion is high. So you have to rule out these things. Now coming back to our topic, adrenal adenoma, or also called as aldosterone producing adenoma. See, general population prevalence of adrenal incidentaloма is around 1 to 2% on imaging, autopsy in young adults, and and up to 3 to 7% in middle-aged adults, and it increases with age. That is, becomes up to 10% above 70 years of age. So as the age increases, its incidence increases. So initially in young, 1 to 2, middle-aged and elderly, you see this. And among patients with primary aldosteronism, this APA. So if you see primary aldosteronism, there can be multiple causes. One among them is aldosterone producing adenoma, that it accounts for 30 to 40% cases. You have to remember this thing. And it's usually unilateral, small, less than 2 centimeter, and it's more common in younger patients. So this is the cause in younger patients, less than 40 years of age, and especially in females. So adrenal adenomas occur in, so incidentaloma prevalence is around 2 to 7% of general population, and its incidence increases with age, but aldosterone producing adenoma becomes the cause for primary aldosteronism in about 30 to 40% of the cases. Whereas this bilateral adrenal hyperplasia, this is the most common cause of primary and accounts for 60 to 70% of the cases. So subtract from 100, you will get 60 becomes 70 becomes 30 here. There is another cause, that is familial hyperaldosteronism, and that is rare but important, especially in young patients with severe hypertension or family history. And it has got 4 subtypes. And first one is familial hyperaldosteronism type 1, that is also called glucocorticoid remediable aldosteronism, that is GRA, and it is due to chimeric gene, that is CYP11B1 and CYP11B2 gene, and prevalence is 1% of primary aldosteronism, but much higher in pediatric onset primary aldosteronism. And familial hyperaldosteronism type 2, there is mutation in CLCN2. Then comes the third, which is KCNJ5. This is some potassium channel mediated, although it's extremely rare. And then comes the last, that's fourth, which is CACNA1H mutation induced. So they are associated with these, and this is more frequent in this case. Familiar hyperaldosteronism is more frequent in early onset disease, and if there is strong family history of hypertension or stroke, then this is the cause. Although rare, overall prevalence 1 to 5%, but should be suspected in early onset. So this should be suspected in early onset, this or familial hypertension. So familial hypertension 1 is glucocorticoid remediable, while others are due to ion channel mutations. These are all ion channel mutations, but this is glucocorticoid remediable hyperaldosteronism. So I will be discussing briefly this familial hyperaldosteronism type 1. Definition: it is a rare autosomal dominant form of primary aldosteronism. It's characterized by aldosterone overproduction that is suppressible by, so this is suppressible by glucocorticoids. Clinically, early onset hypertension, often in childhood, adolescence, sometimes with hypokalemia and a family history of stroke at a young age. So gene involved, we know that it's a chimeric gene formed due to unequal crossing over between CYP11B1 and CYP11B2, and this is 11 beta hydroxylase gene, and this is aldosterone synthase gene. So the result is the promoter of CYP11B1. This I'll make a diagram. So this gene, this is fully this gene, it has got a promoter, and then there is this gene. So promoter of this CYP11B1 usually is ACTH responsive. Now what happens? It is fused to the coding sequence of CYP11B2. So here, so this gets fused with the coding sequence of 11B2. So what happens? So aldosterone synthase, this enzyme aldosterone, this synthase gene, so this gene, it has got now promoter, and that is ACTH responsive. So this aldosterone synthesis, aldosterone, this enzyme, and it will eventually lead to aldosterone formation. So this aldosterone synthase or aldosterone is now under ACTH control instead of the renin angiotensin system. So this gets out of control of RAS. So RAS is no longer in charge, rather ACTH is in charge now. So what abnormal enzymatic reaction is? So CYP11B1, that is 11 beta hydroxylase, it converts, what it converts, usually it converts 11 deoxycortisol to cortisol, and CYP11 beta 2, that's aldosterone synthase, it converts corticosterone to aldosterone. In this glucocorticoid remediable, so this was 11 beta 1 and this is 11 beta 2. So what happens in glucocorticoid remediable aldosteronism? The chimeric enzyme misdirects substrate flow. So aldosterone is produced in the zona fasciculata under ACTH stimulation. We know zona glomerulosa and zona fasciculata. So here aldosterone is produced and here cortisol is produced. This is under RAS control and this under ACTH control. So what it does, ACTH will come here, but because of chimeric gene here, so there is chimeric gene now. The promoter region of CYP11B1 has come from here and it has fused with this. It has fused with CYP11 beta 2, that is aldosterone synthase gene. So I'm sorry, I'll correct this. So you know that this zona glomerulosa produces aldosterone via RAS activation, zona fasciculata produces cortisol via ACTH. So this is under ACTH control and this is under RAS control. And 11 beta 1, this enzyme is responsible for that production, and here 11 beta 2 is responsible for that production. But what happens due to chimeric gene? The promoter region of 11 beta 1, so it gets subtracted here. So here it gets subtracted and it gets joined to the coding sequence of 11 beta 2. But we know that this promoter region is under ACTH control. So what happens now? So now this aldosterone production is under ACTH control because the promoter is ACTH responsive. So one would expect that ACTH now controls the aldosterone production and aldosterone should come more from the zona glomerulosa, but here is the catch. So I'll be explaining this. You see what happens, you have to understand, you have to go to the this physiology first. Zona glomerulosa, it produces it has this both You see, first all cortical cells have both CYP11B1 and 11B2, but it depends which one is expressed. So CYP11B2, that's aldosterone synthesis, expressed in zona glomerulosa, but CYP11B1 is not expressed here because its promoter is not activated in zona glomerular cells. So CYP11B1 is there, but the promoter is not activated in glomerular cells, and this regulation of zona glomerular cells is under angiotensin second and potassium, produces and product is aldosterone. Whereas fasciculata, it has zona fasciculata, it has CYP11B1, and it has this enzyme 11 beta hydroxylase is expressed, but zona fasciculata CYP11B2, it is silent here because its promoter is not active in fasciculata cells, and regulation is under ACTH control. Product is cortisol. What happens in glucocorticoid remediable hyperaldosteronism, familial hyperaldosteronism type 1? There is unequal crossover event. We know that it fuses as I already described, it fuses the promoter, this region of CYP11B1, that is fasciculata specific ACTH driven, with the coding region of CYP11B2, that is aldosterone synthase. So now the fasciculata, because we already know that CYP11B1 and CYP11B2 were here already, likewise here. So what is the catch? Catch is the promoter region of CYP11B1, it gets fused with CYP11B2, which was initially inactive. So now the fasciculata, which normally makes cortisol via this CYP11B1, it now starts expressing aldosterone, because the promoter region, that's under ACTH activation, now has combined with, there is this chimeric gene fusion, now it has combined with the CYP11B2. So fasciculata now has started making or expressing aldosterone synthase, and that is under ACTH control. So here aldosterone is made in the fasciculata, inappropriately regulated by ACTH. This is the catch. So both CYP11B1 and CYP11B2 genes exist in all adrenal cells, but only one is active in each zone because of zone specific promoter activity. And normally CYP11B2 is active in the glomerulosa. So normally this is active. 11B2 is active in zona glomerulosa, and similarly in zona fasciculata B1 is active. But in glucocorticoid remediable aldosteronism, the CYP11B1 promoter drives CYP11B2 expression in the fasciculata. So aldosterone is made there under ACTH control.